This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
With endometriosis, when does surgery help IVF outcomes, and when can it risk reducing the ovarian reserve?
Yes, so endometriosis, certainly endometriosis has four or five stages, depending which classification you use, with stage 1 being just a few spots inside the abdominal cavity, 2 going up to having lesions that are more obvious and widespread, and then you gradually work your way up to the whole pelvis being full of endometriosis. So in 3s and 4s, there is definitely proven a reduction in the chances of success with IVF, and removing as much of that as possible before having an IVF cycle or having an embryo put back. It's the putting back of the embryo that's the issue. So increasingly what's going on is that we are doing IVF before we do the surgery, but freezing the embryos. The logic of that is that surgery, which particularly when it involves the ovaries, if there's endometriosis in the ovaries, removing that endometriosis can destroy a substantial part of an ovary and reduce the number of eggs that are available when we come to an IVF cycle. So ideally, we actually now tend to do the stimulation regime, collect the eggs, make the embryos, then do the surgery, then replace the embryos. And certainly the pregnancy rates with that regime seem to be good, and certainly better than just going ahead without doing anything. For stage 1 and 2, it's much more debatable, but if you've had repeated embryo transfers and not got pregnant and you think you might have endometriosis, it's worth having the laparoscopy done before your next transfer, because there is a little bit of evidence that even for the milder cases, removing the endometriosis may make a difference. The mechanism why endometriosis causes this problem is thought to relate to the sort of toxins that the endometriosis cells have within the peritoneal cavity, and that can get into the uterus. That's the theory anyway. It's never been proven quite why in IVF it makes a difference, but it does, and we do go chasing, particularly the more severe cases. To diagnose it, a laparoscopy is the gold standard, but these days with highly skilled ultrasound services in women's ultrasound services, the diagnosis is much more clear, where particular features are able to be seen on ultrasound and may not require a laparoscopy to prove it. But it is the laparoscopy that allows you to actually treat the endometriosis.
I have a question from one of our live viewers. There's a lot of fear and misinformation around IVF meds. What's one major myth you wish more patients understood?
Well, the issues around problems with medication, certainly it makes women bloated, but it goes away. Certainly it makes women, and because of the bloating and the fluid retention, they put on weight, but it goes away. In terms of risks of cancer in the future, there is no increased risk in an IVF cycle related to the medications. We're just about to publish one of the biggest studies ever and show no increased risk in massive population studies in Australia and internationally of overall cancer risk being affected by having gone through an IVF cycle. So probably that last one is the one that worries people most, because there have been scare papers suggesting an increase in ovarian cancer, but we didn't find it in our study.
Okay. How does adenomyosis affect implantation or miscarriage risk, and what treatment do you consider before transfer?
Well, adenomyosis is where the cells that line the uterus have become embedded in the muscle of the uterus. and therefore they go through the same cyclical changes as the cells inside the womb, and so there can be breakdown of those cells at the same time as a menstruation occurs and causes pain. In terms of its relationship to implantation, it's still debatable. Certainly in mild to moderate cases, the evidence is not convincing that it makes any difference whatsoever, so we tend to ignore it. In the more severe cases, there's various therapies that have been tried, and perhaps they work, but there's been no real proper randomized studies to prove it. So by switching off the hormones that drive the lining of the womb, the growth of the lining of the womb, switching off estrogen, using injections or nasal spray for a month or 3 or 4 or 5 or 6, reduces adenomyosis, but whether it makes any difference to pregnancy rates is very debatable. More recently, using a drug that reduces estrogen levels at a local level, letrozole is that drug, there's been a little bit of evidence coming out now just recently, quite optimistically, that taking it for a month or 2 continuously before an IVF cycle may improve pregnancy rates. So we're waiting to see big studies and randomized controlled trials on that, but certainly it's worth it and worth trying, and it has almost no side effects.
Prof, when it comes to fibroids and polyps, what do you think should be treated before IVF, and what do you usually like to leave?
Yeah, the vast majority of fibroids and IVF, the only fibroids that fibroids in the uterus occur on the outside of the uterus, in the wall of the uterus, and very occasionally impact on the cavity of the uterus, what they call the submucosal ones. They're the only ones that are worth treating, and they are worth treating before doing an embryo transfer. It doesn't change doing the IVF cycle itself because the ovaries are away from the uterus. They can sometimes if they're very big, make collection of the eggs quite difficult, but that's the only impact. The submucosal fibroids we can resect internally using hysteroscope rather than having a big procedure, but that's those. So fibroids, submucosal ones, yes, worth dealing with. In terms of polyps, they're very common, and for an IVF cycle, if we see a polyp, we do tend to curette them out because there is some evidence that polyps can reduce implantation. And of course, when you put an embryo back and it doesn't work and you've got a polyp, you'll blame the polyp. Again, randomized controlled trials have yet to be proven that it really makes much difference at all, because there's a lot of other lining in the womb where an embryo can stick, not involving that particular polyp. So we tend to deal with the polyps, but that's really safety first, and it's a relatively simple process to do with a hysteroscope.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.